I'm Dr. Jason Scoppa. I practice up in Seattle, Washington. I want to thank Charles Blum. He made his font a lot smaller down here, but he really helped to put all this together. I'm not very good at that kind of stuff, so I really appreciate his help in doing this. So it's just a case study. Someone that came into the office, she's a female sprinter complaining of lateral knee pain. Not the best at PowerPoint either, so I apologize. I heard this is too much text for one slide. But so knee injuries are common, especially in athletes. A lot of this is demographic data. Not super exciting, right? But knee injuries are pretty common. I'm sure you all see knee injuries pretty often in your practice. I think this is interesting. Most common diagnosis of knee injuries was a strain sprain. The most common category was sports related. So 18-year-old African-American female, 5'9". She's a semi-pro sprinter. She had multiple college scholarship offers. This was her senior year in high school when this started bothering her. So insidious right lateral knee pain. Started 8 months prior to her visit. It was getting worse and worse and worse over time. At first, it was just bothering her when she was sprinting. And eventually it got to the point where walking, was having trouble just to walk. Sharp, severe, constant pain. 5 out of 10 at rest, 8 out of 10 when moving. She tried multiple forms, multiple therapies before coming to the office. Self-care, Rolfing, physical therapy, rehab-based exercises. She'd gone to an ortho who had ruled out structural damage, the presentation before us. So really no one really knew what was going on. Her track coach refers a lot of people to the office who say you should go see Jason, see if he can do something with it. So yeah, I mean, I didn't do anything amazing. I checked the SOT indicator, like everything that we all know how to do. I mean, I just went through the protocol, checked the SOT indicators. She had a restricted right lateral, fibular head. SOT extremity technique, sensitivity to palpation, right lateral knee, manual muscle testing. Her right IT band and right hip flexors, so it's ASLR, is anterior straight leg raise test, so just legs up, push down, resist. Pre and post exams, which you all are familiar with all of those, I think. Trying to think if there's anything in there that you wouldn't. No, I mean, it's SOT indicators. And the treatment. So I found her to be a category 2. We did supine pelvic blocking. We did iliofemoral. We checked psoas, cleared psoas. Basic 2 cranial technique, and then I use a technique as well called Vector Point, developed by Dr. David Denton. I know some people in here know Dr. Denton, and they'll probably be able to tell you a lot more about him than I can. But I found his techniques to be pretty helpful. He's got kind of an addition to the blocking. There's a certain group of it's almost like a specific sutural technique that he does to help facilitate the blocking, but also to adjust certain spots in the spine. Certain sutures are related to different parts in the spine, kind of like a basic 3, right? You'd spread the sagittal suture for a lumbar, right? It's similar to that. So this is his category 2 protocol that I did along with the pelvic blocking. And this is just straight out of the SOT extremity manual. It's fibular head adjustment. There was an audible. She was freaked out. My knees never made that kind of sound before. And this is we did an intraoral cranial as well. I know it's kind of sacrilegious as it was a category 2, but that's what we did. It's done similarly to Desjarnett. It's just a indirect versus a direct, and the contact is a little bit different, but essentially it's correcting the same. It's an SB plus. Results. So post checks, positive changes that occurred. So we went back and checked the indicators. That's the best part about SOT. She had no pain when walking or standing directly following the treatment. I had her get up and walk around, and she felt better. I had her run down the hallway. She still felt a little bit of pain in her knee. A week follow-up, she reported 60% improvement. Similar treatment was given, except the IT band was not weak, so we did not work on that. We didn't do the fibular head adjustment or the hip flexor adjustment. In appointments 2 and 3, she was blocked as a category 1. And by her third appointment, she was at 90% improved and was able to return to normal workload following her third treatment, which she was obviously thrilled. She was really worried she was going to lose her college scholarship. She was the first person in her family to go to college, so she was obviously really excited about that. So conclusion, given how frequently runners experience knee injuries, I think it's important to know that they have other options available. I don't know if it was all the other SOT work or just the fibular head adjustment, right? I'd like to think it was the whole package that helped. I don't know. But most studies published concerning knee pain intervention, most of it's focused on rehab-based exercises and surgical intervention. I mean, in her case, they couldn't do any of those things because they couldn't find anything, nothing to cut. So yeah, we use SOT pelvic stabilization, SOT extremity technique, and Vector Point Cranial to produce a pretty good result in 3 visits. So got her back to practicing so she can keep her scholarship. So it was good. So this is a patient that came in with acute TMJ pain and dysfunction, treated with SOT and Vector Point again. It's just some info about the prevalence of TMJ, which a lot of really great doctors have talked about TMJ and TMD treatment over the weekend. So many variables are involved, as everyone knows. We've learned this weekend. Numerous clinical signs and symptoms. So it's a really difficult thing to diagnose and to treat. So the recommendations for TMD right now are, it's basically things that are not invasive. So conservative care options are strongly preferred. So those just meaning treatments that do not involve the invasion of the tissue and surgery. Self-massage, pain medication, and those kind of things are kind of what's recommended. And we know that we can usually do better than that. So this patient, a 63-year-old male, really healthy guy, very health conscious. I mean, he teaches me a lot of things. He's read this book and this book. I mean, he's just a really, really health conscious guy. He came in with acute jaw pain, started a few days prior to his visit. He had that kind of jaw pain once before. In 1999, he went in to get some amalgam fillings removed. Got them removed. The dentist said, "Hey, I think you've got a problem. You should wear this splint." He wore the splint, and then he had terrible jaw pain. And the dentist kept adjusting the splint, and finally the jaw pain went away. A couple years later, he ditched the splint and hadn't worn it since, hadn't had a problem. Just a couple of days before, he just started having an issue. He had pretty intense pain, couldn't open more than 2 fingers width, and he'd been on a liquid diet since it started. So rest, massage. He had gone to a couple of other people in those couple of days prior to seeing me. He had cervical adjustments done by an upper cervical chiropractor and a Carrick Institute-based neuro chiropractor. He had tinnitus in both ears for 10 plus years. Not related to this, and it just insidious. It had just started. It was kind of a low. It was pretty low on his complaint list. Obviously, the jaw pain was this big deal, but that was there. So exam, so SOT exam, Vector Point, which uses a lot of this, almost all the same indicators as SOT does. He added a couple, but it's really similar. Pre and post, I think you guys will know most of those. We muscle tested the SCM muscles, trap fibers. Yeah, the other ones are just stock SOT indicators. Treatment, category 2 pelvic blocking, category 2 Vector Point, which I showed before. Stair step at 2-3. He had a right hip flexor weakness, that anterior straight leg raise, and he had a left SCM muscle weakness, which we corrected with the Vector Point. Spinal segments that were treated, and those we used Vector Point as well. TMJ analysis, an SOT TMJ technique, and then intraoral cranials as well. I use the Vector Point. So this is I should have this on the other slide too, but this is kind of what I was talking about, the Vector Point. And then this is the same thing that was on the other slide with the Category 2, which we used as well as the Category 2 blocking. This is the left occipital adjustment. This is kind of, I don't know, both these people, not everybody has left occiput. These just kind of happened that way that both of these people did. But yeah, just everybody who comes in your office is all you need to do. That's what I'm saying. Here's TMJ. So we did the mandibular tracking and setting the capsule. I did both of these techniques. Directly following the treatment, the patient was able to open and close without pain. He was thrilled. Small amount of soreness remained, but he was feeling really good. Obviously, with tinnitus, we weren't able to do anything with it. It didn't change at all. He returned 5 days later, and he felt fantastic. So I mean, it definitely doesn't happen all the time, but when it does, you take it, right? Yeah. He still had the tinnitus. That didn't change. So he's been seen multiple times since. He comes in once every 2 or 3 months now, and he hasn't had a TMJ problem since. So the conclusion, I think, is that there's a lot of other options out there besides self-massage and NSAIDs, I guess, for TMJ pain, which is kind of what's recommended right now. I mean, we can help a lot of people, which we know this weekend, and we've seen some great examples of that. And if pain and function persist, right? So it's a really good low risk conservative care option. There are certainly people, and a lot of people have talked about this weekend, where you don't get those kind of results, and you do need to work with a dentist, a good dentist in the area, and have a good relationship with them, especially if there's a big occlusion problem that you're not going to be able to do much with if you can't get them stable. But yeah, then you also have cases like this, which are great. So that's it. Thank you.
Thanks, Todd.